Good evening, everybody, and welcome to Impact Melanoma's Symposium that we've titled Melanoma Diagnosis, a Toolkit to Support the Journey. I want to give a special thank you shout out to Castle Biosciences. Castle is our sponsor for this session tonight, and we're thrilled to be able to continue working with them to get our message out across the country. Impact Melanoma has been around for a long time. We've been around for over 25 years. And during this period of time, I've been here all of that period of time. So I've gotten to see what's happened when people have a diagnosis of melanoma. In those days, 15 or 20 years ago, when somebody had a stage 2 diagnosis, we would say, oh no, there's not really a lot that we can do. And that when we heard people had more intensive diagnoses, we just thought, oh, this is going to be terrible for them and their families. Fast forward to 2023, 24, 25, and the world is changing for melanoma patients. And I think that's the exciting thing about this is that we are at a point where melanoma is no longer a death sentence. So one thing that doesn't change here is that hearing the words, I have a melanoma, you have melanoma, is still terrifying. So what we want to do tonight is to provide you with some tools. These tools will help you, that we're hoping these tools will help you with the challenging time that you have after diagnosis. And I think this is a really important thing. So if you're a patient, we're here for you. If you're a caregiver or a family member, we're here for you. And for all of our students out there, we want you to have the tools so that you understand going forward what your patients are dealing with. We think this is a really, really important piece for you. So I'd like to introduce Kelly Bragna. Kelly is the manager of our patient support program at Impact Melanoma. She manages our Billy's Buddies program, which is a one-on-one mentoring program for patients and their families, and also our support groups, which are both in person and virtual, so that we can manage folks all over the country. And we also have a caregiver program for those of you who are caregivers out there and just need to have some contact with people that are struggling the same ways you probably are. So with that, I'd like you also to think about taking a moment to take a look at our website after this event for more information on all of the work that we do. So enjoy. The way we're going to work tonight is after each section, we will stop for Q&A. So please feel free to put your questions in the chat. So I think that would be helpful. So Kelly, I'm going to turn this over to you to introduce our presenters for the evening. Thank you.
Thank you, Deb. Hi, all. I'm Kelly Braga. I'm really excited to be here tonight, and I have the privilege of introducing our speakers this evening. First up, we have Mitchell Hansen and Brianna Spiegel. Mitchell Hansen is a fourth-year medical student and MPH candidate at the Medical College of Georgia with interests in public health, dermatology, and medical media. Through Impact Melanoma, he has led sun safety initiatives across the Southeast, managing nearly $40,000 in grant funding. Mitchell has presented internationally, published in journals, completed his MPH internship in Vietnam, and was recently inducted into the Gold Humanism Honor Society. Brianna Spiegel is our other speaker this evening. Brianna is a first-year medical student at Boston University's Chobanian and Avedisian School of Medicine and a Killichan Honors College Scholar. Passionate about dermatology and advocacy, she promotes Impact Melanoma programs across Massachusetts and Florida. Brianna has presented award-winning research, published multiple works, and currently serves as social chair for the BU Student Committee on Medical Student Affairs. So we're thrilled to have you both here this evening to kick us off, and then I will introduce our final speaker, Dr. Erin Farberg, in a little while.
Thank you so much, Kelly, for the introduction. Hopefully everyone can hear me okay. But yeah, I'm Brianna Spiegel, and I'll just be talking a little bit about ways that we can protect ourselves from the sun because I think there's so much information out there online and it's really easy to get lost in the weeds of it. So what I aim to do is to create a really simplified approach, bringing together some of the pinnacles of impact melanoma strategies, as well as some of my own personal tips and preferences. So I created what's called the 4 S's of sun protection, which in order from what I think is, the least amount of individual effort to sort of the more intensive effort, but still important to do. And in order it goes shade, style, sunscreen, and skin checks, both for yourself as well as seeing a provider for those. And because I'm a med student and we've tried to find ways to remember things in funny acronyms and such, I thought about my favorite meal. And so in order, it goes shells, like mac and cheese, steak, and a sundae equals score, equals success. But that's just my own way of remembering these 4 S's, but feel free to come up with your own as you try to implement this in your daily life, as we hope. Okay. So the first pinnacle of this is shade, as I said. So you've probably heard online you want to minimize your time in the sun from the hours of 10 a.m. to 4 p.m. And if you do have to be in the sun, the idea is to try to find shade in a way that works the best for you. So whether it's a playground, having a picnic under a shade structure like you see on the left, or if you're at the beach, we love cool cabanas over here, and they're really easy pop-up structures to set up. You just fill these bags with sand, and they're super easy to assemble and bring down. Or you can think about tents that you see in the far right corner as another way of protecting yourself with shade, despite, wind or other weather conditions that may arise. The next one is style. So when we think about style, the first thing I want to emphasize again, as we've all know, tanning beds are really dangerous and pose a really high risk, both for survivors and all people in general who may be at risk for melanoma. So considering things like, spray tans or self-tanning lotions and things like that as an alternative. And then when we also think about style, thinking about clothing from head to toe, a wide brimmed hat, a long sleeve rash guard, and maybe even pants. When you're finding clothing, it's good to look for something that has a UPF of 50 plus rating. So UPF is kind of like the clothing's version of an SPF that you might see on sunscreen. And then also, of course, picking sunglasses, try to find things that have this sticker like I've shown on the bottom right, where it says UV 400 or sun protection like 100%, something like that to really make sure you're blocking out the rays with your sunglasses. And the next one is everyone's favorite, which is sunscreen. And I've heard a dermatologist say this, and I really like this phrase, is the sunscreen that you like is the one that you use. So as long as you meet these sort of basic principles, for example, looking for something that's SPF 30 at least, looking for something that's broad spectrum, meaning it covers UVA and UVB rays, and something that's ideally water resistant. Once you meet those minimums, it's really a personal preference of one that feels good to your skin and that you enjoy. So there's a little debate going on about mineral versus chemical sunscreens. Mineral sunscreens work by blocking the sun rays by sitting on the surface of the skin, whereas chemical ones actually go a little bit deeper into the skin and absorb the sun rays. For that reason, when you apply chemical sunscreens, something to note is that you want to make sure you're giving about 20 minutes for those to sink in before you're heading out into the sun. I think it's really hard to remember drug names. So when I see things like titanium dioxide and zinc oxide, I know that we're in the mineral bucket of sunscreens. And there, of course, there are other considerations too for specific populations. On the right-hand side, I put some of my personal preferences. I'm a big fan of this Aquaphor lip sunscreen because again, don't forget your lips. They're part of your face, part of your skin, and having burnt chapped lips is no fun. And then also I put an example of ways to combine sunscreen into your daily routine, such as by getting a facial moisturizing lotion that you use each morning that has some SPF in it. So when we think about sunscreen, we want to know how much should we be applying. So when we're thinking something like a cream-based sunscreen, about a shot glass worth for the body, and the face about a quarter to a third of a teaspoon is the general guideline. So this is a good visual, I find, to help remember. Um, and then also making sure that we apply every 2 hours, and then 80 minutes after 80 minutes of swimming or sweating and activities like that. Again, if you're using something like a spray, you really want to make sure you do 4 sweeps or so, and rub it in. I know it's easy to just spray it and forget it, but trying to be very careful when using that method too. And stick sunscreens as well, making sure to rub those in. And the last pillar of this is skin checks. So for melanoma survivors, the recommendation is once a month, but again, talk to your provider for further details about how often to do this. And I'm talking about self skin checks in particular. And so I think the easiest way to do this is to just take a look at the body, kind of step by step, the front side of the body, the back side, maybe getting someone to help you, especially looking at the back and the back of the legs. Making sure to lift the arms, looking through the scalp as well, and take pictures of spots that come up, things that look like something like the ABCDEs, as we say, of melanoma, where they're a little bit asymmetrical. Maybe they have a funny border, maybe they have multiple colors, they're bigger in size than a pencil eraser, and maybe if they're changing over time. And so take a picture of those and follow those along, and bring those photos to your dermatologist at your um, monthly or however often visits when you visit them. But if something is really new, if it's changing, if it looks dramatically different from the others, and especially if it's like itching or bleeding, maybe that's a sign to go get that seen professionally. Um, but yeah, at this point, I want to hand it over to Mitch.
Awesome. Thank you, Brianna. Share my screen. All right. Is everyone able to see that? Perfect. All right. So hi there, everyone. My name is Mitchell Hansen. So today I'm going to be kind of talking about what melanoma survivorship looks like, how how this process might be different for everyone in regards to the timeline and how you are experiencing this, and then lastly, actually reviewing in a very understandable way some evidence-based research about what this experience is like not only for melanoma survivors but other cancer survivors. So, what is survivorship? Survivorship are the goals of health and well-being from the time of diagnosis all the way until the end of life. Survivorship is in multiple phases as well. This would include the acute phase of survivorship, being the initiation and end of cancer treatment. Extended survivorship, which would include the effects of cancer and cancer treatment afterwards. And then lastly, permanent survivorship, the maintenance of the extended phase, often years later in which recurrence might be likely. To talk about this process and how it looks for everyone, first of all, is different for everyone. There might be feelings of grief, anxiety, fear of it coming back, and guilt about surviving. The bodily effects might be different for everyone depending on the stage of your cancer, if it's migrated somewhere else, and how intensive of therapy that you require to be able to just treat it. Coping, management, and goals might look different for different people. So your goal might be either, getting back into your career, or either just being able to spend time with your family outside, or being confident in all these different capacities. And then lastly, this cancer diagnosis may or may not be part of your identity. Some people that have this cancer diagnosis want to go on to be an advocate for it and educate others, but that might not be a part of your story that you're wanting to convey. Second of all, this is a team effort to know that you are not alone in this process. This would include having friends, family, coworkers, loved ones, your chosen family, mentors that are all involved in your personal care and well-being. This also involves your doctors that really do care about you and want the best for you, not only just as your patient, as their patient, but also in a mutual beneficial relationship. So this would include like your dermatologist and potentially your oncologist. Both that are going to be key in creating a survivorship plan involving treatment, checkups, and other therapies. And then lastly, and kind of the whole promotion of this is that other survivors who can empathize with your experiences, which we will talk about some resources for on the next few slides. And then lastly, just to kind of look more on a positive note, this is hopefully optimistically improving as time goes on. The awareness of survivorship and what that means among millions of people, and also the scope of what it means for yourself and society, is coming to a better mutual understanding. There are actual laws now, including the American Disabilities Act and Genetic Information Non-Discrimination Act, that protect from discrimination, jobs, and health insurers for that prior diagnosis. We are developing better ways of earlier recognition and prevention of recurrence with increased awareness. Sun protective clothing, as Brianna was kind enough to kind of go over, technology and programming like Impact Melanoma that have aimed at preventing melanoma from happening in the first place. And then lastly, the treatment itself, which we're going to cover later on in our presentation, for immunotherapies, those that use your own immune system to fight the cancer cells, and then also surgical techniques to improve cosmetic outcomes and mortality differences. So altogether, all these are in the goal of creating a brighter tomorrow for you. So getting into what are the shared experiences of melanoma survivors and also other cancer survivors. So one of the common themes is grieving and coping. This might include denial for some people as to whether they even have the diagnosis, refusing treatment, or even to acknowledge it being a thing for them. Shock, that could be a very common one for people that don't have a family history of cancer or skin cancer, have lived a healthy lifestyle, trying to stay out of the sun as much as possible, or if they're of a younger age. Guilt and a spiritual blame, as if they did something wrong or caused something in the universe to cause this upon themselves. And then lastly, feeling overwhelmed with all the new appointments and discussions and treatments that have to be had. Sometimes it's better, and your doctors might recommend it, to spread out your appointments to kind of reserve some of those for different types of conversations that you're going to have, to where you can really take all the information in at one time and make a very informed decision. The other experiences include adjusting to a new normal. That might include maybe having fear or a threat of losing parts of your identity. So maybe you're a caregiver for your loved ones. Maybe you're really in a high functioning capacity of your job or workplace. Or maybe you have goals of traveling to all these different foreign countries or running a marathon. You might have to adjust those plans along the way to see how you can tackle those while dealing with your diagnosis. It might feel like there's maybe a difficulty to maintain independence, where you might have to rely on others for a few other usual responsibilities that maybe you can handle like normally around the house. And also maybe unusual lifestyle changes, so where maybe you're having to take more naps and more time between tasks during the day to recuperate. Lastly, one of the other things is anticipatory anxiety, meaning that you might believe the rest of your life will look like this. You're trying to cope with this and how loved ones and finances might be affected in the end. And then the sense of exclusion from others with your diagnosis, so where maybe you don't feel comfortable going out in the sun, and you might feel like you're kind of excluded from these other activities. For our caregivers that are online with us, and thank you so much for being here. I know your family members and loved ones really do appreciate your role and what you play in this. So I wanted to also talk about how we can be there for our loved ones with melanoma and also even other cancer survivors. So this would include practical support. So that could include including them in events and invites, even if they don't want to come or can't come, just because you're thinking about all your buddies and your loved ones. Of course, you're going to invite them to whatever gathering that you're going to do. Treating them like you normally would. Now, of course, there are moments where you want to kind of dive into discussing their feelings, but that's often better led by them into that conversation. Helping them with their chores or responsibilities, but doing so in a very casual way. So, for example, this might look like, oh, do you want me to go pick up dinner and then I can go by and pick up the kids for you, rather than having to drag in their diagnosis or maybe some of the reasons as to why that task might be difficult for them. Asking permission whether whether they want you coming to an appointment with them or not, to where you're not kind of over impeding on their identity and their ability to feel like they have control in this. For the dues of emotional support, which are on the left side of the little heart icon, this can be to admit, this is awkward, or I can't imagine what you're going through. Simply listening to them, even if that means having silence to where they feel like they have the space to be able to express themselves, and also even including like open-ended questions to be able to allow them to speak rather than having just a definitive yes or no. And meet them where they're at. This has been a really important thing in a lot of recent research, that, if they are sad, it's okay to be with them in that moment rather than trying to fully drag them up. For the don'ts of emotional support, on multiple websites and resources that kind of talk about cancer survivorship, kind of saying, I know how you feel exactly in this moment. Whether you have cancer, another type of cancer, that cancer, or no cancer at all, that experience might be totally different for you, whether it be, your culture or your family lifestyle. So straying away from that. trying to really empower them to, you can beat this, you can power through this, it's all in God's plan. Telling them it will be all right in the end it might invalidate some of their emotions. Providing some unsolicited advice. This can be annoying just in the first place, but especially if you're in the scenario where you might not be having to deal with the same circumstances that they are. And then lastly, making their cancer their identity and bringing it up constantly. They also want to feel like a normal human being. And then very lastly, of course, as the caregiver, this can be a burden on you as well, whether you view it as a privilege or honor for your loved one. This can be a heavy weight. So, leaving space for you to have feelings of anxiety, worry, and tiredness, and being able to prioritize your own mental health and well-being during this. This caregiver role has oftentimes required people to honestly leave their job or maybe take a little hiatus from some of their activities that they like, exhausting some of the resources, spreading yourself thin. It's very normal to feel like it's a difficulty to find a balance, and really focusing on your own health also in that time will help maybe to maintain some of that balance in the end. And then very lastly, be prepared that some people may not know how to react with the caregiver role on. So maybe that's a sibling in your family that's trying to take care also of your parent, whether it be due to their time, their own problems, finances, or maybe even emotional barriers involved. So getting into some of the amazing resources that Impact Melanoma has, there are several support groups here on the screen for patients, some of which that are in person at the allotted times on the right side of the screen. We also have some more national patient groups as well. And then two other things. One that was mentioned earlier was Billy's Buddies, that one-on-one peer support program with trained melanoma survivors. And then lastly, that national caregiver group, which is also important to know that you are not alone in that experience. But I'm going to stop sharing my screen now, and we'll be ready to take any questions.
So for anyone on, feel free to use the chat feature, and any questions that you may have for Brianna or Mitch, you can just type that right in there. All right, I don't see any questions. Thank you both so much. We so appreciate your time, your expertise, and I certainly learned a lot. I appreciate you both being here this evening. And I would like to next introduce Dr. Erin Farberg, who's our next presenter up. We're thrilled to have Erin here this evening, Dr. Farberg here this evening.
Oh my goodness. All right, go ahead with the intro. I know.
Here we go. Dr. Erin Farberg is a double board certified dermatologist and fellowship trained Mohs surgeon specializing in skin cancer and cosmetic dermatology. A graduate of Emory University and the University of Michigan, he completed advanced training in plastic surgery and dermatology, including serving as chief resident at Mount Sinai. Dr. Farberg has authored over 100 medical publications and has consulted for the New York Yankees. We are thrilled to have you here this evening, Dr. Farberg. Thank you.
Oh my gosh. Between that intro, I know my mom is like, tearing up, but it's nothing better than having two future bright students. I know they're in medical school, Mitch and Brianna, but this is the future of dermatology, and no quicker way to make you feel older than, to hear all the brilliant things they said. They actually highlighted some really important things. Just this whole idea of adjusting to the new normal, I think, is absolutely key. And Brianna, I don't know if you know, but a lot of the data or the way that you presented it actually came from some of my studies. I actually did a study where we sat people in the middle of a sun umbrella out in a beach here, actually in Lake Louisville, where I'm living here in Dallas, Texas. And we had the people sit right in the middle of the umbrella and move as the sun went over them for hours to sort of see what sort of protection a shade or a sun umbrella actually gives. And the SPF of that was only about a 6. And so I think one of the main highlights that she had mentioned was that it's not just one thing that you need to do to protect yourself and protect your skin. You need to do all of those protective measures, including some sunscreen, including, using the UPF clothing, staying out of the sun during the brightest times of the day. It's not just one thing. I'll highlight another study that I was a part of that was actually used for the FDA labeling of sunscreen. We did an SPF 50 versus 100 on a split face study in Vail, where because you're so high up, you're actually getting more UV radiation there on the mountain than you do in Miami Beach. So a great place to get a lot of sun. And the SPF 100 versus 50, it was actually superior on the 100 side. The reason for that is most people don't put on enough sunscreen. As she said, you're supposed to use quite a lot. Well, most people don't actually do that. And they don't also follow the other rules of reapplying. So if you have that higher SPF, it gives you a slight margin of safety. Now, if you're going to really slather it on and do it right, like she said, SPF 30 is really, what is needed and what is required. So with that, let me, I made a couple of slides because I think it's kind of fun to sort of see everything. It's a lot of words. It's a lot of, don't even bother with the words. It's mostly for me to, talk a bit and give you my perspective on things. As I was introduced, I'm Aaron Farberg. I'm a board certified dermatologist. I did plastic surgery first at the University of Michigan. So when it comes to skin cancer, it's really my favorite topic to treat. And melanoma, of course, is near and dear to my heart. In between those two residencies, I actually did a fellowship with the guy who invented this, the ABC. Oh, wow, I got my alphabet wrong. My little kids would be disappointed. It's ABCDEs of melanoma. And these, again, I know most of you know this, but I still like to highlight it. It's asymmetry. You're looking at moles and you're trying to figure out which ones are concerning. And so you're looking for ones that are asymmetrical, have borders that are irregular, color is variable, so more than one color, a diameter greater than a pencil eraser or 6 millimeters. And this is really an important one that's evolving, one that's changing. There's actually a whole alphabet of mnemonics. So, for those in the med school, you can learn all these different mnemonics, but these are the main ones. And it's just a starting point to figure out, what is a concerning mole that you should get checked out. But this is what we deal with every day. Even as a dermatologist, I look at all these and I go, which one is the melanoma and which one is not cancer and benign, and how can we figure this out? And really the goal of my talk for you today, what I want you to take back is that you have to be an advocate. And I love doing these talks, particularly with impact, because pretty much if you're on here, I already know you're very interested in this disease state. You're already beyond the basics and you understand the importance of really being an advocate. And this goes for everybody, whether you're a caregiver, whether you're the patient, whether you're the clinician, everyone needs to be advocating for the patient at hand here so we can get this right. And so I'm going to give you some of the cooler technologies as to why, A, that they're out there, B, why they're important, and then C, why you really need to challenge your clinical team and ask them, are they doing everything they can do for you? This world's healthcare system, gosh, we don't have enough time to talk about it. It can be very difficult to navigate and very frustrating. And there's all these different players with whether it be the insurance companies or even academic centers, and there's always money involved. But at the end of the day, all we care about is how we can help the patient the most. And so my goal here again is for you to know about some of these interesting techniques and tools and to make sure you're asking for them, or at least, hey, asking, is this appropriate for me? Or, hey, get a second opinion. I don't know if you saw on that first slide, you can have my email. It's actually just my name, Aaron Farberg at Gmail. And I welcome you guys always. You can email me with questions, concerns, just comments, stories about your family. I'm here for everything. This is a cool technology that I use in our office. It's called electrical impedance spectroscopy. The device you can see there is actually, it's called Nevisense or Nevisense. And the concept is that cancer is dysregulated cells and your normal skin is totally fine and totally right. There's organization to it. And some really smart scientists thought, well, if we send electricity through it, Well, if it's nice and organized, it travels quickly. And if it's disorganized, well, it's impeded. And so you can actually measure these electrical impedances. And when you send them through a mole, you can actually develop a device that gives you an output that's important. It tells you, hey, this is likely to be malignant, or hey, this is likely to be benign. And again, all the years of training that I have, hey, even I don't know every mole. I don't get everything right. And so I'm always looking for new technologies to help me identify, what moles should I be biopsying and which ones can I really, just monitor at this point. And so, here's a patient. You got a mole like this. And honestly, if I look at that, yeah, it's got a couple of different colors, so that's one high risk feature. Maybe the border is a little bit irregular over there. I mean, it, I would bet there would be a couple of even well-trained dermatologists that would say, well, maybe we can just watch this one. Because, imagine this is on a patient's back and there's probably 15 of these and they all look kind of similar. So, what do we do? Oh, and by the way, it's a 26-year-old guy. Oh my gosh, like, do I want to put a 26-year-old through a biopsy and a scar? Let's see if we can avoid it. Well, when you use this device, it gives you this score of a 6, which on their algorithm, which is what, the study that they did to really tell you what these risk scores mean, basically said you have about a 22% chance of this being a melanoma. And sure enough, it ended up being a melanoma in situ. And so again, it highlights the value of using technology and why you really want to push your clinicians to, either get a second opinion or for them to use this technology. So now you got a mole that we're worried about and we're going to biopsy it. There's a couple of different ways of biopsying it. You can excise it with an actual scalpel. You can use a punch, sort of like a cookie cutter device. You can incise just a small area of it. Another thing that we can use is sort of like a razor blade, a derma blade, where we do a deeper, flatter shave. It says here that the gold standard is excisional biopsy, but a deep scoop shave is also quite reasonable and sometimes even preferred. Imagine you have like a large mole and you're not going to be able to cut that whole area out. Actually doing a deep shave can be quite appropriate. And so what that is you're just going to have that area numbed and it's just some local anesthetic. That's the hardest part. And then, I or another clinician will do the biopsy. You'll have a little wound there that you'll have to heal up. You'll have a little suture that will come out in a couple weeks later, but then it goes off to a dermatopathologist. And they are the ones that actually look at these specimens under a slide. They look at it under a microscope, actually. And they tell you, is it a melanoma or not? Now, we would all love to live in a world where things were black and white. And basically, if you put the melanoma under a microscope, it waved a big red flag and said, yeah, I'm a melanoma. Unfortunately, that is not the situation. In fact, there's a lot of unsureness to even diagnosing a melanoma. If I took 10 melanomas and gave them to 10 different dermatopathologists, I should say, there will be some variance. Not everyone will agree on the diagnosis all the time. So there is some subjectivity. And that's where I utilize this idea of gene expression profiling. And this is a test actually offered by Castle Biosciences, which was mentioned as a sponsor here. But this is what we use. And it's used by my dermatopathologist, one of my partners in my practice, who has read more slides than anyone in the world. He's coming on 4 million slides. The second best person he's more than 1 million slides behind, to give you an idea of how many specimens he's looked at. And even he comes across a mole once in a while and he goes, yeah, I'm not totally sure if this is a melanoma or not. And so when this happens, he'll order this test. And what this test is doing is it's actually looking at the genes in that specimen, in that mole on that slide. They actually are able to look at the genes in that tumor. as opposed to, a genetic analysis where like, oh, you draw blood or you do a cheek swab and you're looking at a whole bunch of different genes in your body. This one's actually just looking at the genes in your cancer or your potential cancer. And the idea is simple. The melanomas have different genes that are up and down regulated compared to what a normal mole, a normal nevus would have. And that's exactly what this test does. Now, just as a quick, and how does this work? You don't need to do any other biopsies. You don't need to do anything else special. They basically just order this test. The slides get sent off to a laboratory. They're able to scrape off some of that tissue and actually look at the genes that are expressed in that mole. And that's how this works. And this helps the dermatopathologist because, again, they're just not perfect. They need some objective information to really help them figure out what is cancer, what is not. And so this is exactly how our dermatopathologist utilizes it. It looks at over here, you can actually see the genes for the nerds here that are listening and learning. Actually, it'll be a test for the medical students afterwards. The genes that are actually expressed in these melanomas, and the output is simple. It's simple that even a patient can read it. It's likely to be malignant, it's likely to be benign, or actually it's somewhere in the middle and we really can't tell either. You should probably just cut the whole thing out. So this is, again, a really important test that, we use regularly because you just can't trust even a dermatopathologist entirely. They're human beings. They try their best, but they recognize that, wow, sometimes they come upon these difficult lesions. And so it's great to be able to get some objective help and answer those questions. So once they're looking at these slides and you get the diagnosis of a melanoma, then what they want to do is look and see, well, how is it growing? And melanoma has a couple of ways it grows. At first, it'll grow side to side. And if you catch it when it's at that point, it's called in situ. So melanoma in situ. And the good news about those is that when you cut those out, your cure rate's over 99%. So if you want to catch them as early as you can, if you catch them at that phase, you're good. At some point, they stop and they start going downwards into the body. That's when they become invasive. When you hear the word, oh, it's an invasive melanoma, and that's when they become a bit more dangerous. But even then, it's now, well, how dangerous is it? We want to figure that out. And some of the ways we determine how dangerous a melanoma is by a number of different features. The most an important one is this idea of Breslow thickness. And what that is how deep is that melanoma going? I told you at some point it stops and goes down into the body. Great, you can actually measure that. And depending upon the thickness or how deep it's going, it gives us a pretty good guide as to how dangerous this melanoma is going to be. Other things we can look at are things like mitoses, which is how fast is this cancer multiplying? Ulceration is another feature. In other words, if the lesion becomes like an ulcered spot instead of a nice sort of like, black mole. And then there's a number of different features that, we doctors will look at, which, a little bit out of the scope of today's talk. But as I was telling you about that Breslow thickness, depending upon the thickness, it can tell us whether or not, for example, we need to do additional procedures, or perhaps even get imaging, or send you to see a medical oncologist or a surgical oncologist. And this is just a little chart to show you that depending upon how deep it is, there is sort of a guide to tell us, well, if it's less than a millimeter, we don't have to do any other additional procedure. If it's between a millimeter and 2 millimeters, you're going to consider it. If it's above 2 millimeters, yeah, it's highly recommended. Now you're asking, what is this procedure I'm talking about? Well, if the melanoma is dangerous enough, one of the procedures that can be recommended is to do what's called a sentinel lymph node biopsy. And what that is if this melanoma were to have spread it would usually spread to a lymph node first, the sentinel lymph node. And so what that procedure is a surgical oncologist injects a dye right there into the melanoma, and it literally goes where that lymph node would be, and they're able to trace exactly to that lymph node. And then they cut that lymph node out and they check it for cancer. Now, the issue with that procedure is it doesn't actually even help anyone live any longer. It just tells us, wow, this is either already spread or it's very high risk, or actually maybe it's not as high risk as we thought, and it helps us determine what we have to do afterwards. But there's some other fun things that we can do instead of just doing a sentinel lymph node or in combination with the sentinel lymph node. There's actually some more genomic testing that we can do. Now, why is this important? Well, here's the deal. When you get diagnosed with cancer, the first thing you're going to do is try to understand what stage you're at. And staging is very important. However, it's not perfect. What staging is doing is it's taking people with like characteristics. You're this years old with, it's on your scalp, it's gone this deep, Breslow thickness, you have this sentinel node positivity or whatever, and it lumps people with like characteristics together, and you're hopeful that they'll have like outcomes. Whether they're good or bad, they're going to have similar outcomes, because then wow, people in the bad group, well, we need to do everything we can for them. People that are in the good group, well, maybe we don't have to do as much. The problem that we run into melanoma is we're able to diagnose these patients early on when they're very thin. In other words, they haven't gone invasive very much. And even though we're really good at finding those patients early, and they're supposed to have very good outcomes, unfortunately, most of the deaths actually occur in those earlier melanomas, in those originally stage 1, stage 2 melanomas. So again, even though we have staging and we utilize it, and all the cancer institutes in the country will tell you, oh gosh, you're stage 3, you're stage 2A, 2B, 4, whatever. It as patients, I know we grasp on to these diagnoses and these stagings, but you really want to figure out where you fall in your cancer personally. Where is your cancer fall? And with these staging systems, by the way, the recommendations for what to do with them is very wide. Whether you're stage 1A, 1B, or 2A, which are very big different swaths of stages, the recommendations are the same. That's not good. And even if you're a higher stage, really, like, for example, when would I do imaging? When would I get a CT scan? The guidelines say, well, it's really up to you, doctor. And so again, this is where I'm highlighting it's very important to go to the best doctors, because they're going to really know the nuances of your specific disease. And this is the exciting part. The 31 GEP, this is the Decision DX melanoma test. And again, this is from Castle Biosciences. This is now really the standard of care. They've crossed over 200,000 patients that have received this testing, and it's been life-changing for so many patients. And what this does is it takes your patient's characteristics. So you are the patient or your family member. It takes the characteristics that they have of their tumor, and then it looks at the genes in their actual tumor. And with that information, we can tell you specifically whether or not really you should be considering getting a sentinel lymph node biopsy procedure, or whether or not you should be getting imaging, or whether or not, hey, you have a really great positive outcome. Let's hit the brakes a little bit. You don't have to do all this additional testing or procedures. Pretty amazing. And this, I know it's a fun slide. Enjoy this one. But again, those black dots are where we are at with staging, whether you're stage 1, 2, or 3. But that's not good enough for me. That's not good enough for you. That's not good enough for your mother or whoever it is. You want to know where you really fall. And so what this test does is it stratifies. It turns you from that big black dot into one of those small dots. And it really tells you what's your chance of living and dying? What's your chance of this coming back, this melanoma recurring? And it's widely different. You see the spider web. So you're not here. Maybe you're up here and you actually get really, really great news. Or actually, maybe you're down here and you thought you were going to do okay, but no, now you're really worried. And so now you can do something about it. It's not just about making you panicked about the future. It's about really identifying who we should be watching very carefully. And this was studied with the National Cancer Institute. I just wanted to show this slide. What this is showing is stratify. Immediately Google these Kaplan-Meier curves, because then you're given a stage and you're given a stage, and then you're going to follow on one of these paths. And if you stay up at the top, it's a good thing. That's your chances of surviving. If you start going downwards, that means bad things are happening. And it's important for us to know which line of these you're on, because I, as your doctor, if you're on that lower line, well, there's a lot that we're going to do for you. If you're on that higher line, then maybe there's not as much that we have to do. This, just because I wanted you to see what a test report like this looks like, I share this with my patients. You can see right there on the bottom left, that's my patient's numbers. Those are your numbers. Your risk of living or dying from melanoma, of having a metastasis, or having a recurrence. The one on the right tells you whether or not you should consider that additional procedure. This is personalized care. It's very cool. Now, again, if you are now put in this phase where it's an invasive melanoma, and perhaps you did a sentinel node procedure, you then have additional opportunities for more information and more testing. We look at the mutations of your cancer, which is different from the genomic testing I just went through. And then another thing that you might even discuss with your oncology team is, well, do I want to do, I'll call it chemotherapy. But chemotherapy is now sort of old age type stuff. We are now into the age of immunotherapy. Sometimes we still use chemotherapy, so I'm not, throwing that out, out into the alley. But ideally, we're able to utilize immunotherapy, and the way that works, it essentially turns on your immune system, your own body, to help fight the cancer. The best example I have of that is Jimmy Carter. He lived several years after his diagnosis of melanoma, and I would say a decade ago, he would not have lived as long as he did. But with the immunotherapies that we have now, we're really able to treat these patients and give them a real serious chance at, a good life, a good long life. This is a lot more detail than anyone really needs to know. Your clinical team will walk you through all this, but there's a variety of different immunotherapies, chemotherapies. You could consider things like radiation and, of course, clinical trials, which we have as well. And then you have to decide quality of life as well. At the end of the day, the most important person is the patient and how they're feeling, as Mitch has already gone through with that whole psychological experience. At the end of the day, as a physician, I know oftentimes I'll step back and just listen to the patient. We want to make sure that they're being heard and that their wishes and their feelings are the absolute priority. One last sort of plug: once you have this diagnosis of melanoma, I'm going to be your best friend, or your dermatologist is going to be your best friend. There's a variety of recommendations, as you can see here, for how often you should be seeing one of us. And I just like to make it simple. If you've had a diagnosis of melanoma, then you need to be seen every 3 months for the first couple years after your diagnosis. And then it can move to every 6 months thereafter. The other thing I tell everyone is, if your direct family member has had a melanoma, any brother, sister, mother, father, or children, then they should be seeing a dermatologist at least on an annual basis. And the threshold to biopsy just is a little bit lower. And with that, I got to the end. I hope everyone's still awake, and I would love to take any questions and talk further if anyone has any.
Thank you so much. That was incredible. I learned so much. We do have one question here actually from Brianna. Why do lower stages have higher rates of mortality? Is it because of the wide range of recommendations?
It's a combination. The wide range of recommendations is a limitation of just staging. And so it really depends upon really the doctor that you're going to. They can do very different things. Other reasons is simply it's a statistical trick. There are a lot more diagnoses of these early stage melanomas. So even if it's, a less probability that you're going to have a metastasis or pass away, just the simple fact that there's so many more of these diagnoses, you're going to have more deaths in that group. But it really does highlight this idea that really are just binning patients when we stage them, and we want to do better than that. We are in this age now of personalized and individualized care, and more information is good information. And I mean, this testing, again, I already told you, it's widely used. The cost, I would also highlight, the company makes sure not to balance bill any of the patients in the sense that if this information is something you or your doctor or somebody needs for your care, you're going to be able to get it, and the cost will never be prohibitive in any way whatsoever. Super key there. And it's again, it's identifying these patients that otherwise we would just cut the melanoma out and move on, but we know bad things still happen. We just haven't been able to figure out or identify who those patients are. Now with the genomic testing, I think we have a much better lens on those patients.
Thank you. If there's any other questions, feel free to type them in the chat. We have a few minutes left this evening.
Or you could just come off of the mute and not,
There you go, even better.
I'm here for you all.
Any other questions?
I have a question. Do you find this really helps the patient in their journey to hear and understand their therapy and their risk factors? And do you then try to treat the person if their outcomes may not be as beneficial as some others?
Absolutely. Knowledge is power, and it really helps drive behavior. And this goes across the board from a highly educated patient that's coming in, having Googled every single thing that they possibly could, to, I've got a number of, farmers out there that just say, Doc, just tell me what to do. And I don't just tell them what to do. I still present them all this information and the data, and we go through what they're going through in their life. And suddenly they really have an opinion. They really have an understanding of what they're going through. And the greatest outcomes come from patients that actually have an understanding. And this is really a lesson to, I would say, even the clinicians in the room, the future, doctors of our world here. I'll give you an example. My father came back from his cardiologist and he told me, hey, guess what? My heart has a thickened wall. It's stronger than yours. I'm going to live longer. That is the exact opposite of what the doctor explained to them. Okay, let me tell you, having a thickened heart is not good. It's terrible, in fact. But he came to me thinking, oh, it's good. It's going to be great. And so it's our job as the clinical team not to just, move past and go on to the next patient. No, you have to educate everyone. And if they didn't get it the first time, do it a second time. And if you didn't get it the second time, have them come back and keep on educating. They need to understand it. People genuinely want this information, and when they have it, they feel so much better about whatever decisions they make, whether it is to pursue some aggressive management or, hey, I'm good with where I am with that life, and I want to enjoy my family. it makes those decisions so much better and higher quality.
Thank you.
I had one final question actually for you, Dr. Farberg. Thank you so much again for your conversation on this and elaborating on everything that we said. It was very educational. From your experience being a dermatologist, just for our patients and caregivers that are in the room with us still, what are the most common referrals or recommendations for other types of providers or healthcare professionals for some of your patients to see with some of the long-term impacts of like their melanoma with some of the treatments that you kind of talked about?
So I would say when it comes to melanoma, ideally you really utilize a multidisciplinary team. And from the patient perspective, or I would say the caregiver perspective, find an advocate within that team that at least is your go-to. And I highlight the dermatologist as really oftentimes it can be this sort of gatekeeper or this keystone clinician because I'm usually the one making the diagnosis. I might not be doing the immunotherapy, the infusions, I might not be doing the big surgery in the operating room, but I knew the patient first. I kind of see them often. And I know their family oftentimes too. And so I can be an advocate to the other clinical team and help, mention, or essentially provide more of the patient perspective. Because even though, yes, the patient goes and sees these other doctors, there's a lot going on. And the patient's also trying to listen and understand and take in all the information. Their family members, their caregivers are trying to understand everything, that it can be very difficult to also then get your points and your issues and your concerns across. And so that's something where, if you find those advocates, I mean, my patients get my cell phone number and I've got all of my referring doctors, direct contact numbers, so that we can make sure that we're getting this right with every single patient. Because sometimes you need other sort of consultations, psychiatry, it just mostly for, a therapy sort of type, this is an impactful diagnosis as you discussed. And so there's going to be a lot of behavioral changes. There's going to be a lot of life changes. There's going to be, it's going to have an impact on every sort of aspect of their life. And it's best to really be able to offer support in all of those different avenues.
Thank you so much. I think in closing, our executive director, Deb, was going to come on just with a final thoughts.
Thank you so much for being here tonight. I think this was everything we had hoped for with Brianna and Mitchell, and then with Dr. Farber. I think we're talking about the gold standard of the way that we treat patients who are diagnosed with this disease, and that our goal is to make sure that we get to that gold standard. And I think the more kinds of conversations that we have like this, the closer we'll become. So I want to thank you all so much. This was very enlightening. This as this event is recorded, so you can find it on our website going forward. And I just want to thank you all again, those of you who are part of the chat and those of all of you who presented such incredible information tonight. And again, to Castle Biosciences for being such an amazing partner. Thanks all, and we hope to see you soon.